Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today we're going to be talking about chronic GI disorders. Last time I talked about chronic respiratory. This time I'm talking about chronic GI. And I want to have you learn how to look at chronic diseases and determine what they're really asking you about. Are they asking you about symptoms of the disease or complications of the disease or what we have to teach patients? So if you can understand how to answer chronic disease questions sort of generally, you're going to do a lot better on the Nclex. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best Nclex review in the entire universe, in my opinion. Mark Klimek is the GOAT of Nclex reviews. You know that this channel is a part of the greater Clinic Review organization, and our primary goal is to help you pass Nclex. And so you can do our 21 plus hour Nclex review. If you go to clinicreviews.com, click on the on demand tab or drop down and you'll get there. We also have a streaming service where you can watch all the videos that I put on YouTube and even more through our streaming service. And then we also have small group tutoring. If you want to meet me live on Zoom, you can sign up for our small group tutoring. So let's go ahead and get started with our chronic GI questions. A nurse assesses a client with ulcerative colitis, which finding requires immediate intervention. Cramping and urgency before bowel movements, 10 bloody stools in the past 8 hours, low-grade fever of 99.5, anorexia, and mild weight loss. So what requires immediate interventions are unexpected findings. Expected findings, if they're admitted with ulcerative colitis and it's an expected finding, I don't have to do anything about it because that's why they were admitted, okay? So cramping and urgency before bowel movements. Well, that's expected with ulcerative colitis. 10 bloody stools in the past 8 hours, that is not expected with ulcerative colitis. They may have some blood in their stools, but if they're having 10 bloody stools in 8 hours, that's a really big risk for dehydration and bleeding. That's a big problem. So that's unexpected. Low-grade fever, that's fine. I don't even consider that a fever. It might be low-grade temperature. I usually say anything up to about 99.9 is considered within normal limits, unless they told you that they run cooler than that. So I'm not worried about 99.5. Anorexia and mild weight loss. Again, that's expected with ulcerative colitis. So what is unexpected is the 10 bloody stools in the past 8 hours. A client with cerosis is scheduled for a paracentesis, which finding is most concerning or is most concerned about unexpected findings: elevated INR, hypoalbuminemia, abdominal distension, or poor appetite. So I like this question because when I read it, I said, well, we're looking for the unexpected finding because that's what's always most concerning. But all of these are expected. These are all symptoms of cirrhosis, okay? So then I have to go back and reread the question and say, wait a minute, these are all expected. So what are they really asking me? And if I reread it, a client with cirrhosis is scheduled for a paracentesis. So I go, okay, so these are all expected, but which one of these would be concerning if you're having a paracentesis? And a paracentesis where they put a large bore needle into the peritoneal area and they pull fluid off of there, right? So if I say which one's most concerning if you're going to put a large bore needle in through someone's skin, would be an elevated INR because they're at risk to bleed. None of the others would really be concerning specific to the paracentesis, except for the elevated INR. Which teaching point is most appropriate for a client with GERD, gastro esophageal reflux disease? Which teaching point is most appropriate? So I'm looking for the right thing to teach a patient with GERD. They have refluxing back up into their esophagus and it causes burning and discomfort. Lie flat after meals, increase intake of spicy foods, take antacids before meals, or avoid carbonated beverages. So we're looking for something probably that's going to prevent reflux, right? So lying flat after meals is not going to prevent reflux, because if you lay flat, then just your positioning is going to allow for more reflux after meals. So that's not a good idea. Increase intake of spicy foods. I would think that would increase gastric acid secretion and could increase reflux. Take antacids before meals. Okay, so taking antacids before meals, that is that just doesn't make sense. Why would I want to take antacid before the meal? It seems like I'd want to take the antacid like at specific times, like in the evenings, for example, because laying flat does increase your risk for reflux. So it seems like I would want to take the antacid as prescribed, first of all, but also if I got to choose, I'd rather do it in the evening. So before meals doesn't make a lot of sense. Avoid carbonated beverages. So carbonated beverages, okay, so I drink a lot of carbonated beverages and it's never caused reflux for me. However, if you read the textbook, the textbook's going to tell you that carbonated beverages can increase reflux. And the Nclex tests on general principles. So it's never a good idea to go, well, that doesn't bother me, so I'm not going to pick it. Like, that's not a good idea. You got to say, what in general does the textbook say about this, right? And so D is correct. The others, A and B, are completely wrong. And antacids before meals is not the appropriate time to take antacids. So I have to go with D. A nurse is preparing for a client with chronic pancreatitis. Which instruction is most important to reinforce? Chronic pancreatitis. Avoid alcohol use. Limit carbohydrate intake. Increase protein in the diet. Discontinue pancreatic enzymes if no pain is present. Chronic pancreatitis. All right, pancreatitis. So, most important to reinforce. Okay, is alcohol going to do any damage in chronic pancreatitis? I would say yes. Seems like alcohol would exacerbate pancreatitis. So, it seems like avoiding alcohol is a good idea. Limit carbohydrate intake. I don't see how that's going to help. It seems like when people have a chronic disease, you have to make sure they get enough calories to manage that. I'm just talking generally speaking, right? So remember, these are, I'm helping you think the way you should think. So the whole point of most of the videos that I do is not about teaching you content. It's about teaching you how to think, because probably half of the Nclex questions you're going to get, you're not going to specifically know the answer to, and you're going to have to think through it. So I'm teaching you how to think. This is what's really important. Now, obviously, I know what the right answer is. Okay, so don't think I don't know what the right answer is. I wrote the stinking questions. What I'm doing is I'm helping you think through it as though I didn't know what the answer was. Okay, so it seems like alcohol would exacerbate pancreatitis. Limit carbohydrate intake. Again, if I think just generally as far as chronic diseases are concerned, I think I don't usually want to limit caloric intake with a chronic disease. Increase protein in the diet. Usually I want to, if I'm going to increase calories, I usually want to increase protein quite a bit. Discontinue pancreatic enzymes if no pain is present. So that's sort of generally never right answer. Discontinue your meds if you're not symptomatic. When it relates to chronic diseases, that's like never the right answer. So I'm going to cross off B and D. And I'm going to say, well, it seems like it would be a good idea to increase protein in the diet. But this is a most important question. So if I don't tell them to avoid alcohol use, I say, don't worry, alcohol's okay, but you should increase protein. Or I don't tell them to increase protein, but I do tell them to avoid alcohol. Like, which is going to be more harmful? Is alcohol going to be more harmful, or is a low protein diet going to be more harmful? And I would think alcohol would be more harmful. Now, in this case, you have to use general principles. General principles is what you use with a question like this. And this is why Nclex is hard. So I'm going to pick A. This is why the Nclex is hard. It's not because the content is so difficult. It's because you have to use clinical reasoning to get to the right answer. A nurse is reviewing discharge teaching with a client with diverticulosis. Which statement indicates understanding? Diverticulosis. I will eat a low fiber diet. I should avoid all physical activity. I will include whole grains and fruits in my meals. I'll use laxatives daily to stay regular. Discharge teaching for a client with diverticulosis. So diverticulosis is those little pouches in the GI tract that can, like seeds and different things can get stuck in there. And it can develop diverticulitis, which is an inflammation from all those things getting stuck in those little pockets. So, but diverticulosis is treated primarily with dietary changes. So is a low fiber diet appropriate with diverticulosis? Well, low fiber is going to cause constipation. I don't really think low fiber is good with diverticulosis. I should avoid all physical activity. So I never say avoid all physical activity unless there's an absolute 100% reason to do it. I can't imagine telling them to avoid all physical activity. That's ridiculous. I will include whole grains and fruits in my meals, whole grains and fruits. So that has fiber, that seems healthy, whole grains and fruits, that seems good. I'll use laxatives daily. No, we don't use laxatives daily, y'all. Don't do that. They become laxative dependent, and it's not considered a good idea to use laxatives daily. They can use fiber, they can use fluids. Those are kind of things that are okay, but laxatives are not considered good to use on a regular basis. So I know A and B are wrong. I know D is wrong, and I like whole grains and fruits in my meals. So, and I know diverticulosis is predominantly treated with dietary changes, and low fiber diet is not a good option. So I'm going to pick the other dietary change. Which finding in a client with peptic ulcer disease should be reported immediately? So we report unexpected findings immediately. Epigastric burning relieved by eating. That's expected with peptic ulcer disease. Melena. If you don't know what melena is, you should. It's black tarry stool. Melena. Black tarry stool. You should know what that means. Intermittent nausea. I don't know that's expected. It could happen. Mild abdominal bloating. That could happen. I don't know how often it happens, but it could happen. If you know what melena is, then probably the answer is pretty obvious. You don't expect blood in the stools. Peptic ulcer disease means they have an irritated area in the stomach that is causing pain, right? Peptic ulcer disease. And if it's bleeding enough that you're getting blood in your stools, that's a problem. That needs to be reported immediately. All the other things are relatively benign symptoms of peptic ulcer disease. A client with irritable bowel syndrome reports alternating constipation and diarrhea. Alternating constipation, diarrhea, which is typical with IBS. That's what IBS is. What is the best nursing intervention? Recommend opioid medication, encourage daily dairy intake, provide high-fat meal options, or suggest increasing fiber. So fiber is an interesting intervention because it can be used for both diarrhea and constipation, interestingly enough. So fiber is a good Nclex answer for GI problems. Now, opioid medication could be used if they have constant diarrhea, okay, because opioids will slow down the GI tract. So they could do an opioid medication if it's really bad diarrhea, but that only addresses the diarrhea. It doesn't address the constipation. Daily dairy intake often causes just irritability in the GI tract, so I don't like that. Provide high-fat meal options. I'm never going to recommend high-fat unless there's some specific reason to it. And fiber, uniquely, out of many foods, can actually treat both constipation and diarrhea. A client with Barrett's esophagus is prescribed omeprazole. What is the expected therapeutic effect? Promote gastric motility, increase stomach acid, suppress acid production, neutralize acid in the stomach. So omeprazole is a proton pump inhibitor, and you should know that. You don't have to know every med in the world, but you should know omeprazole is a proton pump inhibitor, and Barrett's esophagus, the symptoms are like GERD. Okay, so if you don't know what Barrett's esophagus is, but you know it's like GERD, just say a client with GERD is prescribed omeprazole, and you're going to similar answer. Okay, so what's the therapeutic effect? Well, we know A and B are not right. So is it going to suppress acid production or is it going to neutralize acid? It's going to suppress acid production. That's what PPIs do. Proton pump inhibitors, proton pumps pump out acid. So if you inhibit them, it suppresses acid production. A nurse is teaching about preventing hepatic encephalopathy in a client with cirrhosis. Which instruction is most important? Eat high protein meals, take lactulose as prescribed, avoid physical activity, use non-steroidals for pain. All right, so a patient has cirrhosis and they are prone, a complication of cirrhosis is elevated ammonia levels. Elevated ammonia levels can lead to encephalopathy, which is confusion, changes in level of consciousness, eventually can lead to death, suppression of the respiratory rate and all that kind of stuff. So Hepatic encephalopathy. So encephalopathy is sort of a generic term, which means changes in level of consciousness, changes in, confusion, changes in level of consciousness. That's sort of what encephalopathy sort of is, a generic word, meaning that. You can look it up if you want to. I've looked it up. It's a very generic definition of it. So hepatic encephalopathy just tells us that this problem in the brain is being caused by something in the liver. That's all that means. So what instruction is most important? Eat high protein meals. Well, actually, high protein leads to greater ammonia levels because as protein is broken down, it releases ammonia. So protein is not good to have when they're at risk for encephalopathy. Take lactulose as prescribed. Lactulose actually binds with ammonia and excretes it in the stool, causes pretty bad diarrhea, but it does excrete ammonia, so B is okay. Avoid physical activity. That's not going to do anything one way or the other. Use non-steroidals for pain. Non-steroidals for pain, that's not going to do anything for ammonia. And it's not encouraged because people with cirrhosis are at risk for bleeding anyway because of the elevated PTINR levels. And non-steroidals are not a good option for cirrhosis. So I'm going to go with the take lactulose as prescribed. Which finding is expected in a client with celiac disease? Weight gain and constipation, steatorrhea and weight loss, jaundice and pruritus, bradycardia and hypotension. Now, I'm going to answer this question like I don't know what celiac disease is because I bet there's some people out there who don't know what celiac disease is. I can't be the only person who's not that familiar with it. So I'm going to pretend like I don't know anything about it, okay? So what I'm going to say is celiac disease, I know, has something to do with the GI tract, and that if you eat certain types of food, that it causes irritation and a lot of issues, right? So what I'm going to look for is GI symptoms. Since I don't know much about celiac disease, I'm going to say, well, I'm going to look for GI symptoms. So A, weight gain and constipation is GI. B, steatorrhea, which is fat in the stool, and weight loss is GI. Jaundice and pruritus, that's liver. And I know celiac is not a liver problem, so I'm going to cross off C. Bradycardia and hypotension, that's cardiac. And so I'm going to cross that off. Now, listen, I'm telling you, when you don't specifically know the answer, how you can use common sense and clinical reasoning to answer it. So I'm looking at celiac disease. I say, I don't know much about it, but I know it's GI. So I'm going to say with GI disorders, is it more likely to have weight gain and constipation or steatorrhea and weight loss? So are they more likely to gain weight with this disease? And I say, well, they have all these GI problems when they eat certain foods, right? With celiac disease. So I wouldn't think weight gain. When I think of GI disorders, I don't think of weight gain. I think of weight loss because usually if you have a GI disorder, you're not absorbing things. You're losing a lot of stuff through your GI tract when it's not working right. So I think weight gain's not very typical. Steatorrhea, that's a pretty common symptom for a lot of different GI disorders. It just means you're not absorbing fat very well. And weight loss means malabsorption, right? So if I have to guess at which one is most likely celiac disease, I'm going to pick B just based on knowing it's chronic, it's GI, and it's an absorption issue. Now, if you want to look up celiac disease, you want to learn all about it, that's perfectly fine with me. But I'm here to tell you, you cannot know everything before you take the Nclex. You cannot know everything. It's impossible. So don't even try. Now, there are some fundamental things you have to know. That's why I've done so much stuff with the Blue Book. The Blue Book is what Mark Klimek has published. I just got a bunch of facts I've done that you need to know. And I've done a bunch of videos to go along with that. If you just Google Blue Book, on YouTube, just search Blue Book Klimek. A lot of the videos that I have done will come up to go along with that. If you want to learn more content, you can take our Nclex review that Mark does. You can do our tutoring or our streaming. So you're welcome to look all that stuff up. This channel is not primarily teaching content. This channel primarily is getting you ready to take Nclex. And I'm just telling you, you don't need to know every single thing about every single body system in order to pass. Which complication should the nurse assess for in a client with longstanding ulcerative colitis, which is an autoimmune inflammatory disorder of the GI tract? Colon cancer, acute cholecystitis, appendicitis, or peptic ulcer disease. Okay, ulcerative colitis is GI, and it is primarily lower GI. So since it is predominantly lower GI, I'm going to look for lower GI complications because I don't have a list of complications associated with ulcerative colitis memorized. Like I didn't memorize that. If it was asking for symptoms, I could just look for the things I expect to happen with ulcerative colitis, but it's asking for complications. So it's basically saying what problems can this lead to? Not symptoms of the disease, but problems can it lead to? So it's an autoimmune inflammatory disorder, primarily lower GI. So colon cancer is lower GI. Acute cholecystitis is gallbladder. As far as I know, uh, UC doesn't really have anything to do with the gallbladder. Appendicitis, again, not lower GI. Peptic ulcer disease, not lower GI. Although it is GI, it's upper GI at least. Like I like D better than I like B or C. So, and if I don't know the answer specifically, remember half the questions you get on Nclex, you're not going to specifically know. So you have to have a strategy. So I'm going to go with lower GI colon cancer. So I think to myself, is there any reason why ulcerative colitis could lead to colon cancer? And I think, well, it's a chronic inflammation. It's the same with Crohn's. Crohn's is also chronic inflammation. So it's a chronic inflammatory disorder. Does chronic inflammation, can that lead to cancer? Well, if you get chronic inflammation on your skin, that certainly can lead to cancer, right? So if you have chronic inflammation in your lungs, that can lead to cancer. So why couldn't it lead to cancer in the GI tract? So that just makes sense. So if I just use my common sense and clinical reasoning, and I think UC is colon cancer is colon, like, does that make sense at all? Like, if I couldn't make it make sense at all, then I could look at the other answers, but it's not that hard for me to make it make sense. And it's better to use common sense and clinical reasoning than to just guess. Like, don't just guess and go, I don't know, I guess I'll just pick anything. Don't do that. Okay, that's not a good strategy. Which nursing action is a priority for a client with portal hypertension and esophageal varices? Which nursing action is a priority action? Monitor for hematemesis, administer antacids, encourage coughing exercise, elevate the head of the bed. Okay, so this portal hypertension and esophageal varices are associated with cerosis. And I don't want to do a big, long explanation of cerosis, but what the liver itself does receive oxygenated blood from the heart. Okay, it does receive oxygenated blood from the heart, but the majority of the blood that goes to the liver comes from all the other GI organs. So almost everything, almost not all, but almost all the blood that returns back to the heart comes from the liver. And that's because it's that final filtration. Now, it does have to get oxygen from somewhere. So it does get fresh blood from the heart through the hepatic artery. But all the other GI organs, the large intestine, the small intestine, the pancreas, the stomach, all these other organs send blood to the liver for it to be filtered out. And the way the other organs get blood to the liver is called the portal vein. Okay, so they leave the other organs because it's got unoxygenated blood leaving in other organs, and then it goes to the liver. That's called the portal vein. So if there's a problem with the liver and the liver can't filter a lot of that blood, a ton of blood going to the liver, like just almost all the blood in your body is going through the liver, right? So if it can't handle all that blood, it starts to back up, and it starts to back up into the portal vein. And that's called portal hypertension. Okay, so portal hypertension, then where does it back up? Well, it can back up. Remember, all the organs of the GI tract send blood to the liver. So it can eventually back up into the esophagus. Like that's the kind of the last place it's going to back up to, but it can back up into the esophagus. You can back up into the rectum. It can back up into the stomach, right? But eventually it can back up into the esophagus. And that's called esophageal varices when you have enlarged veins in the esophagus, and they can rupture. That's a big risk. Okay, I'll just say most people who die from cirrhosis die from bleeding out. Eventually, they can maybe manage all these other symptoms, but eventually, a lot of times they end up bleeding out. So it's a big problem. And so they have esophageal varices. So I'm really concerned about bleeding out. So monitor for hematemesis. It says, which is a priority. So monitoring for hematemesis seems like a priority. Now, administering antacids, I've always learned to be one of the primary interventions as well, because if you have too much stomach acid and you cause a gastric ulcer, that can also sort of start to cause a lot of bleeding, and then you hemorrhage out. So I like B as an answer, encourage coughing exercise. That's actually the opposite of what you want. You don't want to encourage coughing exercises because that can cause rupture. Elevate the head of the bed. I like that answer. I do like that answer, generally speaking, but it does not seem as important to me as A and B. Now, this is a priority question, so I can only do one thing. This is not a first question, it's a priority question. So I say to myself, if I can only do one thing, is it more important to monitor for bleeding or to administer antacids? And it's hard for me because I know administering antacids is important because we don't want to cause irritation to the stomach lining and cause bleeding. However, with these priority questions, I can only do one thing, which means I'm going to monitor for bleeding, but I'm not going to give antacids, or I'm going to give antacids, but not monitor for bleeding. And I say, I have to monitor for bleeding. I have to monitor for bleeding. So when you get a priority question like this and you get it down to 2, you've got to imagine only doing one thing. Like you do the one thing and then you report off to the next shift. Like if I gave antacids, but the next shift says, where are they bleeding? And I go, I don't know, I didn't check. Okay, well, that's not good. Or if they say, are they bleeding? I go, yeah, I checked, they're not bleeding. Well, did you give them their antacids? You know, I didn't have a chance to do that. They're going to go, well, you should have, but okay, I'll give it to them. Right? All right. Which assessment finding in a client with Crohn's disease suggests a fistula complication? A fistula complication. Now, remember, a complication is something that's unexpected. It's not, when I say unexpected, you're not like, oh my word, I can't believe I've never seen this before. That's not what I mean by unexpected. I mean something that's not a symptom of the disease, right? You go, oh, this is a problem. Like this isn't just a standard symptom. Now, a fistula is a complication of Crohn's disease. However, that they're not really asking about the symptoms of Crohn's disease. Really what they're asking about is what are the symptoms of a fistula? Now, a fistula, if you don't know what it is, it's a hole somewhere where God did not put a hole, okay? So a fistula development with Crohn's means there's a hole somewhere in the colon, okay? So that means they're leaking GI contents into the peritoneal area. And you go, well, that's not good. Okay, so in general, fistula is not good. So it's a sort of a strange question because you go, well, a fistula is not good, but what do you mean by complication? I go, something that you go, well, all right, I would expect this with a fistula, even though we're going to get them to surgery, we're going to get them on antibiotics, get them to surgery and get this repaired. Like this is something more. This is something even more. Okay. So elevated temperature. Well, that's, I haven't read the answers yet. Elevated temperature, severe abdominal distension, constipation for 2 days, stool leakage from the vagina. So, and I think if you've got a little bit of stool or GI contents leaking into the peritoneal space, what I expect an elevated temperature. And I go, well, yeah, the immune system's going to go, whoa, what's going on here? We better activate the little soldiers and try to take care of this. So I would expect an elevated temperature. Severe abdominal distension. That's probably, out of all these symptoms, that's probably the one that I go, that's really the one. Like that's a big problem with fistula. That's a lot of times that's the earliest symptom. They start to have a distended abdomen. They go, what's going on here? I don't feel good. Constipation for 2 days. Well, that's if it's not going out through the rectum, if it's coming out through a fistula into the abdomen, that means you can have constipation. So that's pretty expected with a fistula. Now, stool leakage from the vagina. Okay, if we have stool leakage from the vagina, that means we have more than just a GI fistula. Okay, for Crohn's disease, I expect a GI fistula, but I don't expect a fistula into through the vaginal wall. That means something, they have a complication of the fistula, right? Now it's leaking out through somewhere else. So that's a big problem. And when I say a big problem, the whole thing is a big problem. But we go, that's something more. This isn't just a fistula in the GI tract. Now I have a fistula for some reason in the vaginal wall, and we're going to have to do a little bit more extensive surgery than I originally thought we were going to have to do. A nurse is caring for a client with chronic hepatitis B, which action prevents transmission. Chronic hepatitis B from blood and body fluids, transmission through blood and body fluids, which action prevents transmission. wearing gloves when administering oral meds, hand hygiene before client care, disposing of needles in sharp containers, or assigning the client to a private room. Are there any I can cross off? Well, assigning the client to a private room is unnecessary. You don't get credit for doing more than is required. They just want to know if you know what you have to do. Like, this is required to do it. You don't get extra points for doing more than what's required. And this is blood and body fluids, which is standard precautions. This isn't contact precautions. It's not droplet. It's not airborne. It's just standard precautions. And standard precautions does not require a private room. Okay. So I'm going to cross off D. Disposing of needles in sharps containers. Yes, it's blood and body fluids. I absolutely have to do that. Hand hygiene before client care. Well, I like hand hygiene. Like, it's the best way to prevent transmission of anything. So I'm going to leave it on my list. Wearing gloves when administering oral meds. So some of you probably were taught by your clinical instructors to always wear gloves when you administer oral meds, but I'm here to tell you that is your instructor's recommendation. That's not a CDC recommendation. It may even be your hospital policy, but it's not generally a rule. Because blood and body fluids, saliva is not a big carrier of it. So you don't have to wear gloves when you give oral meds. Remember, you don't get credit for doing more than you have to do. So I'm going to cross off A. So A and D are out. So I always get thrown when I see a question that says hand hygiene, because I always think, I'm picking the hand hygiene because that's the best way to prevent transmission. However, I know that you have to dispose of needles in sharps containers because it's blood and body fluids. So I say to myself, what is this hand hygiene thing? Hand hygiene before client care. That's pretty specific. Before client care. It didn't just say wash your hands. It said hand hygiene before client care. So before I ever touch them and I wash my hands, is that going to prevent anything I get from them? Well, no. I would have to do hand hygiene after client care. Okay. So now my brain goes, okay, maybe the point is that I would need to do hand hygiene after client care. So I have to dispose of needles in sharps containers. I have to do that to prevent the transmission of hepatitis B. A nurse is caring for a client with hemochromatosis. What teaching is appropriate? Increase iron-rich foods, take iron supplements, avoid vitamin C supplements, and eat liver and red meat frequently. Okay. I put this one on here real intentionally because I want to teach you again how to use good common sense and clinical reasoning when you're answering Nclex questions. This is a testing strategy, okay? So I don't know what hemochromatosis is. And I say, well, I know hemo is blood. Okay, so heme is blood. So it has something to do with the blood, like red blood cells. So I say increase iron-rich foods. Well, it seems like that's a good intervention for something having to do with the blood. Take iron supplements. That seems like a good idea for red blood cell stuff. Avoid vitamin C supplements. I don't know. Eat liver and red meat frequently. So here's the big problem. A, B, and D all are the same answers. And don't say, well, isn't it better to get it from meat than it is to take it in supplements? Maybe. I don't know. Probably not. I mean, we can say that, but I don't know that there's any evidence of that. And A is the same as D. Increase iron-rich foods. A, B, and D all say the same thing. Y'all, if 2 answers or 3 answers all say the same thing, none of them are right. Okay, you cannot pick between them. You cannot. And you may have had a teacher who one of the answers was iron supplements and one of the answers was red meat. And you go, she wanted me to pick red meat. Fine. That was your teacher, what they wanted you to answer, but that's not an Nclex rule. So if I can't choose A, B, and D, I have to choose C. And this also is consistent with another rule when you're guessing. And Mark Clement calls this the Sesame Street rule. The Sesame Street rule is which one of these is not like the others, which one just doesn't belong. You know that Sesame Street or kids program where they have like a book and a square and a tire and then a phone, like an iPhone or whatever. And they go, which one isn't like the others? And there's 3 square things and 1 round, and you're supposed to pick the round. So which one of these isn't like the others? And you go, well, A, B, and D basically are all saying the same thing. C is completely different. I have no idea if C is the right answer, but it's the only one that's different. And since I can't pick any of those, I have to pick C. And guess what? C is the right answer. So if you don't know what hemochromatosis is, it's elevated red blood cell count. It's actually, I'm sorry, elevated iron. It's elevated iron, which can lead to other problems. So it's an elevated iron, and vitamin C actually promotes the absorption of iron. So you should avoid vitamin C because you don't want to increase the iron that you already have high levels of. Okay, y'all, the things that I teach you here, they don't work unless you practice them. They make a lot of sense when I'm going through them. And every once in a while I get a comment. Someone's like, this was so easy. Okay, I know it's easy when I'm doing it with you. Like, it totally is easy when I'm doing it with you. But you have to practice these strategies. Practice using common sense and clinical reasoning. Practice reading the question, reading the answers, reading the question again. If you get it down to 2, think about reread the question. You get it down to 2, reread the question, see if that doesn't help you. And then think, what are the red flag words? Is this a priority question? Is it a first question? What is it asking me, right? All right, I won't belabor that. I have lots of videos that you can watch that will help you learn those things. So I hope you have a great rest of your day. Thanks for watching and being a part of our family.